It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Welcome back. This is Dave Rosenblum, and I am excited because we have so many things coming up in the next couple months. First, ASIPP, then my course in Tampa, May 14th. Hope you can come. That's an ultrasound course with Arun Kalava. Then in June, we have the board review course in Dallas, which brings me to today's podcast because I'm actually preparing for that course, and I'm going through some of this information with a fine-tooth comb, and I'm realizing that I'm not sure if I agree with some of the standards that have been laid out there, so I'll let you guys decide. We'll get into that soon. But I also wanted to mention in July we have Aspen coming up. On May 18th, I'm working with Upside Health to bring you a practice management webinar where we're going to discuss maximizing patient care, revenue, etc., with remote patient monitoring systems. And more to come. I'm going to be releasing some more courses. I'm working on a few other things. So just stay tuned to the Pain Exam or an NRAP newsletter, as well as the YouTube channel and more. So what happened was I was working on a lecture for the board review with the main topic for this one being anticoagulation and risk of bleeding for these pain procedures. And I have a whole PowerPoint prepared for this for the board review course, and if you can't come to Dallas, you can do the Zoom. So the Zoom is available for those of you who want to do a pain management refresher or actually study for the boards. It is a board review course, however, it could be a refresher for the rest of you, so be sure to check it out on the Pain Exam website. But I decided to look at our authorities who put out the information. And this is more of an editorial. Okay, these guys are sifting through tons of data and hopefully coming up with the best possible information for us, unlike me, who's basically just sifting through what they did and comparing it to a few other things and giving you either a condensed version or their opinion. And this is more my opinion. So I'm looking at ASIPP's guidelines and written by all the huge names at ASIPP, Dr. Machikanti and company. But there are some things I kind of wasn't really sure about, and I'm just thinking out loud here. And what I'm looking at particular is the part where they stratify risk based on procedures performed. And I admit I have not done the extensive research that these guys have done, but there are a few things that caught my eye. And on their tables, there's one table categorizing it's entitled Classification of Interventional Techniques Based on Potential Risk for Bleeding. And it goes low, intermediate, and high risk. So thinking out loud here, trigger points and muscular injections I consider low risk. They add piriformis. When it comes to bleeding, I still think, piriformis is probably a higher risk muscle injection because you could stab the sciatic nerve, but in terms of bleeding risk, probably low risk. Peripheral joints, low risk, agreed. Peripheral nerves, low risk, agreed. Sacroiliac joint and ligament injections and nerve blocks, low risk, agreed. Caudal epidural injections, they list that as low risk, which I agreed in the past and subsequently had conversations with neurosurgical colleagues who explained to me, and I don't have any proof for this, but that they basically told me there's a ton of blood vessels in the caudal space and you need to be careful. That being said, I did a little more digging on my own, And it turns out that, rightfully so, I give credit to ASIPP because of there is some data supporting caudals as being fairly low risk. Now, of course, it's really hard to know with this stuff because the studies are not that extensive, and in America, many of us are just too scared to do epidurals on blood thinners, which rightfully so, medical legally as well as safety for the patient. But in digging, I found an article, Caudal Epidural Steroid Injection in the Setting of Remaining on Anti-Thrombotics, a retrospective study. The background is that ASRA currently recommends ceasing anti-thrombotic medications for all spinal epidural injections. However, there's a paucity of data on the true risk of spinal epidurals via various approaches versus the risk of cessation of an agent as it relates to the underlying medical condition. So they looked at a few hundred patients here who received epidurals, and they were taking anti-thrombotics. They were excluded if they were not taking anti-thrombotics. Age, indication for injection, including MRI, CT, anti-thrombotic medications, and medical condition were all collected. So basically, of the 443 injections included in the study, 51 encounters were lost to follow-up. The 392 injections were analyzed, and there were no complications regardless of patient's imaging findings, age, thrombotic medication used, or underlying medical condition for which an anti-thrombotic medication was indicated. This was retrospective, therefore prospective studies may have yielded fewer encounters lost to follow-up. Patients were not contacted directly after the procedure, and chart reviews were utilized to evaluate for complications which were limited to the patient's reporting of perceived complications without any imaging. They conclude that the caudal epidural steroid injection can be performed safely in patients taking anti-thrombotic medications. Catastrophic events have been observed in those who have discontinued the anti-thrombotic agents preceding procedures. Thus, discontinuing anti-thrombotic medications may pose a greater risk than benefit for patients on anti-thrombotic medications who have painful lumbar radiculopathy. So just a little background about the caudal. I love doing caudals. I find them to help quite a bit. It's the oldest form of epidural injection, first described by Corning with cocaine in 1885. It's been modified to be done with fluoroscopy. You can use a 22 gauge or a 25 gauge needle. Some people use a 17 gauge 2E needle. And the needle is typically placed through the sacral hiatus, but not advanced beyond S3 because you don't want to pierce the thecal sac. You can get a wet tap down in the caudal region. Once the needle is through the sacral hiatus, the medicine can be delivered epidurally regardless of how close it is placed to S3, and this has been confirmed with contrast many times. Of note, I've done these with ultrasounds many times, but now CMS is not reimbursing for that unless the patient is pregnant, so keep that in mind. The reference will be in the show notes, but you can look at them yourselves. In the discussion after, they do mention that further consideration should be taken to regard the caudal epidural as a lower risk procedure than other intermediate risk procedures. Prior authors, including those in medical education textbooks, claim that the caudal epidural injections pose a decreased bleeding risk compared to more cephalad epidural injections, and these are reasonable treatments for patients on antithrombotics. This is based on one study of 37 anticoagulated patients and 19 thrombocytopenic patients who underwent caudal. A total of 336 blocks were performed using either 25 gauge 1.5 centimeter needles or 25 gauge 3.8 centimeter needles. The needles were, once the needles were thought to be advanced through the sacrococcygeal ligament, medication was injected, the needles were then removed, no hematoma or neurological complications. The details regarding specific antithrombotic agents were not provided, and there was a systematic review of over 2,400 articles in which 120 of them were relevant to patients undergoing anticoagulant medications, while undergoing image-guided procedures concluded that hemorrhagic complications were exclusively reported during interlaminar injections and spinal cord stimulator placement removal. Complications were seen at the cervical, thoracic, and lumbar levels, but none were reported at the caudal level. They found no complications at any segmental level. Transfemoral injection, sacrolateral branch block, zygopophyseal or sacroiliac joint or medial branch block, or radiofrequency neurotomy. This was consistent with two large studies that looked at the rates of epidural hematomas and spine procedures in patients regardless of antiplatelet or anticoagulant medication that showed epidural hematoma in only 2 out of 69,000 patients between two studies. Although it appeared to be low risk with these procedures, we recommend further prospective studies before these procedures can be deemed safe while continuing antiplatelet or anticoagulant medications. So, I personally have always been on the cautious side. I'm a cowboy with certain things. When it came to blood thinners and neuraxial analgesia, like most of you, it was a no-no. Now, ASIPP, and this article is supporting, says that caudal epidurals are low risk, which was my first feeling. So am I going to be doing caudal epidurals on patients who are taking anticoagulants? Well, I haven't been. I don't know if I will be, but I did have a thought. One thought is, what if, and you know me going to the ultrasound as always, you put Doppler on your ultrasound and you look at this sacrococcygeal ligament. If you don't see any blood vessels, why not do it? And you can see through the, in fact, I've seen through the bone. If you see some of my videos on caudal epidurals, yes, the needle disappears as it goes into the bony tunnel, but while the bone is still thin at the beginning, you can see the bevel of the needle after it's passed behind the bone. So the ultrasound is penetrating through the bone and seeing behind the bone, I guess because the needle is way more dense than that bone at that level. Anyway, I think this is a very special consideration for that patient who is unable to stop a blood thinner but is desperate for relief. And I do think, in my personal opinion, that you should consider giving patients pain relief when they're stuck in this position. So I may integrate it into my practice. I may not. It's, the problem is the medical legal aspect. We're trying not to practice defensive medicine, but at the same time, if you do perform some sort of neuraxial procedure and wind up getting a hematoma, even though this article says it's low risk and it's safe, the fact of the matter is they'll pay some other doctor to say that you committed malpractice, breach of duty, or negligence, or et cetera. And I think that's a big factor that doctors have when considering these types of procedures. I think if the patient was, I don't know, just thinking out loud, what if the patient was your parent and they're not going to sue you? Would you do it? So I just pose that as some food for thought. Anyway, one more thing I wanted to mention, reviewing these guidelines, very interesting, is they consider the caudal epidural low risk, but they consider the medial branch intermediate risk. And I'd argue maybe in the cervical spine it's intermediate risk, but a lumbar medial branch is quite low risk. Maybe L5 because you could fall off the sacral alar and actually go deeper than you're supposed to. Maybe a higher risk procedure than, I don't know, the peripheral nerve block or possibly even the caudal. But I look at medial branch nerve blocks as quite low risk for bleeding. I don't routinely stop blood thinners for this sort of procedure. There is some flexibility in these guidelines, by the way. It's not like everything is concrete here. Read them carefully. Of course, the risk also changes if they have renal failure, coagulopathy, and then there's other things to consider. But we're going to go over this at the course in Dallas. I hope you guys can come. If you can't be there in person, sign up for the Zoom lecture series. It's 3 days, and if you can't make all 3 of them, it's going to be recorded so you could log in and view them afterwards. It's all for CME credit. There's the breakaway ultrasound course on the Sunday of that weekend, so I'm very excited to see you guys there, and thanks for listening. Once again, if you can make it to Tampa May 14th, great. If not, I'll hopefully see you at another course or conference coming up. Check out the May 18th practice management webinar, and stay on the newsletter so you get all the updates and discounts and options to opt in for these webinars, etc. Thanks for joining me. Have a great day.
In response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, clinical, recording, or otherwise, without the prior written permission of the author.